Hi, I'm Dr. Stein. I am a neuropsychologist on 5 North, and I'm here today to talk about one of the most exciting things that have happened in the field of psychology in the past 20 years, and that's motivational interviewing. Motivational interviewing was put together about 1999, 2000 by Scott Miller, and it is a trans-theoretical, empirically validated model of how people change. And what's fascinating about the motivational interviewing model is it's universal. It doesn't matter what kind of change we're thinking about doing, it fits for any kind of change. Whether it's a positive change, meaning that we're trying to add in something into our life, like starting an exercise program or starting to participate in a diet, or whether it's negative, meaning taking away something from our life, like quitting cigarette smoking, cutting down on alcohol use, or anything along those lines. It fits for major changes and it fits for minor changes. Most of the time, motivational interviewing is something that we do implicitly without even noticing it. So Scott Miller was able to identify 3 important parts of motivational interviewing. He defines it as sort of a client-centered method of finding out intrinsic motivation and resolving ambivalence. So when people come to us in 5 North, there are stages of change, and I would estimate that about 85 to 90% of the people that come to 5 North come to us in the action stage of change, meaning that they're ready to go start therapy, ready to take some of the care into their own hands, well socialized because maybe they've been on a different unit and they hit the floor running. Our job is to keep them in that action stage and to maintain that. A smaller percentage, maybe 15 to 20%, come to us in the pre-contemplation or the contemplation stage. And those are people who are ambivalent. And ambivalence is the enemy of change. So what happens is they often are resistant to change. And most people will say that they are in denial, but it's not denial, it's resistance. Because change is difficult, because it's easier to stay the same, and because the truth is that we tend to go back to our old ways. The stages of change, which we'll talk about in a minute, is a cycle. And I like to think about it more like an upward spiral. Each time we pass through each stage, we actually make improvements as we go. But people get very upset when they relapse or they have setbacks, and they often stop participating. So what we need to do is to get people unstuck. So often what I hear is when people are refusing therapy, occupational speech therapy, physical or nursing, is that the first thing we do is we run to them and we ask them, why don't you want to participate? Or what's going on? What can we do? And what we have to do with the stages of motivational change is we have to ask the right questions at the right time. Because firstly, we have to have a base. As I said, is that motivational interviewing is client-centered. And that is we recognize we're not the experts, the patient is the expert. They have agency, they have the ability to choose ultimately whether they want to participate or not. Motivational interviewing is also supportive, not argumentative. We're not out to coerce anyone, we're not out to threaten anyone. So as we do that, we build a therapeutic alliance. As we build a therapeutic alliance, patients trust us. And that's when we can use the different tools that have been developed through motivational interviewing. One of my favorites is what we call a decisional balance. If people are ambivalent or stuck about participating, instead of asking them outright, why don't you want to participate? Because that's going to slow them down, that's going to keep them stuck. A better question is, what are the positive aspects of staying the same? What are the positive aspects of not participating? So it's the opposite of what we usually ask, okay? And what we often find out if we have good rapport is they'll start a conversation. And that is, well, if I don't participate, I won't fail. If I don't participate, I'll be able to stay away from pain. If I don't participate, other people will start to take care of me. These are important motivators. When I'm often in case conference or hear people talking about a patient, they will say this patient is motivated or not motivated. And my response is always, there's no such thing as an unmotivated patient. They just might not be motivated in the way that we want them to be motivated. We all have at all times competing motivations for most of our big decisions in life. And that's what keeps us stuck. Ambivalence is simply an easy word, what we call it's a bias, where we hold 2 competing thoughts in our head at the same time. And what happens is when we hold those 2 competing thoughts, we get stuck. So if we ask them, what are the positive aspects of staying the same? and we get these responses. And then we ask them, what are the negative consequences of staying the same? Things like, well, I won't be able to use the bathroom. I won't be able to travel. I'll be a burden to my family. At that point, we open up a dialogue where we can help them to move through the ambivalence by figuring out ways where we can manage their most concerns about not participating and capitalize on the positives of participating. Because as experts, you all know if these are what their concerns are, you can tailor your treatment, you can tailor your exercises so that those things are avoided while you're making progress, moving them from the pre-contemplative contemplation, which is maybe I'll participate, to the planning, because that's what you start doing, is saying, well, why don't we try this or do that? And so what we start to do is we start to anticipate obstacles based on their motivations, moving them into the action stage, finding reinforcers to keep them going through each of those stages, and then making sure they don't relapse. But relapse does happen on our unit. People have setbacks, medical, psychological. They might be doing really well at some point, but 2 weeks can be a long time on the unit, and they might decide at some point that it's not worth it. So what we start to do is we start to help them move through that change of relapse by talking about two important things. Self-efficacy, which is the ability that you have the ability to do this, and response efficacy, which is the response is going to be advantageous to you. Once they move through the cycle once, they tend to move through the cycle quicker and quicker and quicker and stay in that action stage longer if they do relapse. So these are easy interventions. They start with listening. They start with asking what might appear to be to you the opposite question of what you usually ask, because you're trying to get the negative response, not the positive response. Working with them, keeping them flexible, and then helping them to move through those changes as a team and as a collaborator. Okay, any questions?